Hi, everyone. Good afternoon. We're going to give everybody 1 minute to enter into the webinar and we'll get started. Good afternoon, everyone. Thank you so much for joining us. My name is Jamie Strauss. I'm the Chief Clinical Officer at VizAI. I'm excited today to be hosting this webinar with 3 amazing physicians who have built comprehensive stroke programs across the country. I'm going to allow them to go ahead and give their introductions. As a reminder, if you have questions throughout, please enter them into the Q&A section, and we'll open up to questions and answers and panel discussion at the end of the webinar. So at this time, Dr. Ruchir Shah, would you like to introduce yourself?
Yeah, hey, good afternoon, everyone, and thank you for having me. I'm Ruchir Shah, one of the vascular neurologist and a stroke program director at the CHA Memorial Hospital, and we are located in Chattanooga, Tennessee.
Dr. Lima? Oh, you're on mute.
My name is Jose Lima. I'm a neurointerventional, work also at CHI Memorial in Chattanooga. And then I built the program here about 1 year ago.
Dr. Tanweer?
Hi, everyone. Dr. Omar Tanweer. I'm the Director of Cerebrovascular Neurosurgery here at Baylor College of Medicine and Baylor St. Luke's CommonSpirit Hospital here.
Great. At this time, Dr. Scheer, would you like to go ahead and get started and share your experience of building a stroke program?
Yes, let me share my screen.
So for those of you in the neuroscience space and the stroke community, you know, we're really measured by Get With The Guidelines and achieving the ability to build quality improvement and outcomes for our patients and our programs. There's really strict criteria that is needed to be able to achieve a Gold Stroke Plus award. And I'm really excited to hear how these programs have paved the way. Go ahead, Dr. Scheer.
All right, thank you. Thank you once again for this introduction, and thank you for having me on this panel. It is an interesting question, how to build a Gold Plus Stroke program. And when we think about it, every hospital has different resources and different culture, and they are uniquely located in different geographical culture. So it's just you have to use your best resources and have to build on that. We are just going to share our own experience and journey, that how we have come and how we have built the program, and hopefully that gives you some insight. So by saying that, I would like to start with where we are located. As we mentioned, we are in Chattanooga, Tennessee, surrounded by the Tennessee River and beautiful mountains in the south. It's a place for many big companies, as mentioned on the slides, and also been featured in many magazines. That it's one of the pretty awesome place if you like outdoor activities. We are located right in the buckle of the stroke belt. So we see a lot of complex stroke cases here in this area, and we cover all the 140-mile radius, all the way from Georgia, North Carolina, and Alabama. So we cover a pretty large area when it comes to comprehensive stroke services. It's very important to give us some background. Where are we coming from? How did we start our journey? And the journey was mainly started by our program director, chairman, Dr. Tom Devlin, when we were at the previous institution with him, where we drove the stroke volume all the way from 600 to 2,500 in span of 15-20 years. And if you see the data in 2019, the Erlanger Hospital, where we were before, that was the 3rd highest discharges in the Medicare discharges, and the highest discharges overall in the US. So we knew how to build up a stroke program, how to get the volume. And with that experience and with that team members, we decided to join the CHA Memorial Hospital, which is a part of the CommonSpirit Health Network. So the benefit of coming here with the CommonSpirit Health Network, it's the 2nd largest hospital health network in the US. So it's not just we are making changes at the local level, but whatever we are learning or implementing, it's also we are kind of trying to make changes at the national level with this big hospital systems. So when after all our team members join here, so we know that how to build a stroke program, how many people you need. You need an army of people when it comes to the stroke program. It's not a single stroke director or one coordinator can achieve all the things that we are trying to do here. So you need an experienced neurologist, interventional team, 24/7 service line manager, multiple nurse practitioners, stroke coordinators, and research coordinators, and data analysts, outreach staff, telemedicine coordinators, and proper RN staffing in the hospitals. And it's also important not just to have all these people, but they are all behind the same mission and the same vision. Then only you can achieve and have the successful stroke program. So with that experience and things in mind, when we joined here, we also made a national neuroscience service line. So as I say, the CommonSpirit is part of the second largest hospital health network. It has a few of the finest neurological institutions like Barrows, Baylor, St. Luke's, CHI St. Vincent. So this neuroscience service line basically co-chaired by Dr. Tom Devlin and Dr. Ganesh Rao, with our service line manager, Diana Brown, and has several subcommittee in that, like a stroke subcommittee led by me and Dr. Chetan Rao, the neurointervention committee by Dr. Lima and Dr. Tanveer. So whatever we learn, whatever we adapt, it's basically the goal is to have it at the national impact at the national level. So this is our proven philosophy over the period of years, that how we have these things in the core of our program, that it's very important to be part of the translational clinical research to be a successful program. So because that turns into your reputational value, it drives your volume and payer mix, which ultimately increase your financial growth and optimization, which is so important and necessary when it comes to when you need a massive infrastructure for the stroke, taking care of the stroke patients. And ultimately, this translational research and the financial growth can ultimately turns into the best quality patient outcome, which is kind of goal of all our stroke centers. So you can see on the left side, like when we were part of the SWIFT Prime trial, not just that we were the highest enrolling site for the in the US, but also one of the biggest achievement was that we also had the best patient outcome across all the centers in the US. So we are very proud about that. So it does not just come with the one person. It's as army of people, as I mentioned in previous slides, that require to achieve that best patient outcome. It is also very important when it comes to we just talk about the clinical care of the patients and how the patient outcome, but all this ultimately you have to understand the finances around the stroke program. And we are not going into too much detail about the finances, but it's very important when it comes to successful stroke program that you understand the finances very well, and then only you can achieve all this massive infrastructure which can translate into the outcome. So your clinical team members are like critical to optimizing your program finances. They have to identify financial saving within your program, identify coding and documentation errors, and basically that drives overall financial growth within your department. So it's important to ask those questions to the hospital and be a part of the finance committee to learn about how your stroke program overall doing. So with all this philosophy in mind and over the period of years, how Viz AI has helped us to achieve some of this goal and how it's a core of our workflow in the hospital and having the good outcome in the patient. So as you all know, like a Viz AI is like, it's a definition of disruptive technology, but how is it transforming the standard stroke workflow? So basically, in the previous slide, I show you that we need a research, we need a patient outcome, and also we need a basically financial understanding. So at each step, I think Viz AI help us to achieve some of those goals. Of course, the utmost importance when it comes to the stroke care that we have a coordination of the care, communication between the different team members, and having a one platform that everybody are connected, including not just the people from the hub hospital, but from the spoke and hub hospital, they can see what's going on with their patient. So it definitely transforming to reducing the door in, door out time, door to needle time, and door to joint puncture, which is ultimately translate into the patient outcome, reduce the length of stay, and help with the hospital economics, right? It basically increase the thrombectomy volume, increase the medical DRG to surgical DRG, and also VZI successfully has helped us with the loss mitigation with NTAP payment as well. These are like the basic features on the Viz AI, just mainly for acute ischemic stroke platform, but there are many other platforms for hemorrhage, aneurysm, which they will talk about it at the end of this talk discussion. But this is basically, you can see the mobile CT, CTA, CT perfusion right on your phone, automated detection of the LVO, CT perfusion, and the most important, as I mentioned, is a communication between team members. So with that help and our vision and how with the artificial intelligence and Viz AI, how we have transformed our workflow over the period of years. So this is like more of a traditional workflow that you usually see, that patient comes to the hospital and they seen by ED physician. And then it will, if it's a stroke patient, they will go to the CT scan, and the CT scan read by radiologist, and then they will decide, the radiologist call the CT result, and they will decide whether the patient need a TPA. And once the TPA received, patient will get the CT angio head and neck. And if it's a LVO, then basically they have to wait for radiology read, and then it's a LVO, the ED physician will call the spoke a hub hospital, and then the hub hospital will page the on-call neurologist. On-call neurologist call again transfer center, make a decision, and then decision to transfer. And depending on how much time it is in between, when the patient comes here to the hub hospital, they might have to repeat the scan, repeat the images, and then they activate the IR team. And if it's not during the daytime, that IR team has to come in, and they come in, and then thrombectomy performs. So that basically takes us such a long time. And with the help of this technology, with the new workflow, we have transformed this workflow into many, like very minimal steps. So the new workflow, we kind of removed all the steps that when patient comes to emergency department, evaluated by MD in the emergency room, and we remove all the steps, and they read by, where patient has a CT scan, it's available right on your phone to review and sent out to all the team members, and mainly reviewed by stroke neurologist, interventional, if it's a patient is a TPA candidate or thrombolytic candidate, make a decision there, give the TPA right there on the table, and then do the CT angio head and neck. And if it's a LVO, review again by stroke neurologist intervention. If it's a LVO, the VCI will send that LVO alert within 4 minutes from after CTA completion. So all the hub and spoke hospital are reviewing. The beauty of this model is now the hub hospital doctor actually pick up the phone and call the spoke hospital, hey, what's going on with your patient? And get the information. If it's a true LVO, then we arrange a state transfer to the hub, and at the same time activate the angio team, and both patient and the angio team are coming together in the hospital. And usually patient go directly to angio if it's a good time, and we save a lot of time by doing that. So in all this, it just doesn't work with the spoke and hub. As I say, it just in the hub hospital itself, it's all the team members are actively in the loop, and they are communicating with each other, and they know what's going on with their patient, where is the patient at that particular moment. So it is, even for internal thrombectomy, internal workflow, it has helped tremendously as well. So how we have transformed with this workflow and how we implemented into real world cases. So Dr. Juicy Lima will kind of take you to the journey of that, how we have implemented this workflow into the real world. Thank you once again.
Thank you, Dr. Shaw, for sharing, and I'm glad to see the big improvements you've been able to make in your workflow. Dr. Lima, you're on mute.
Thank you one more time. Yeah, so thank you, Viz, for inviting me. So I'm going to talk about more this workflow in the neurointerventional part. As I said, so I am a neurointerventional. I started this program about a year and a half ago. So as the first sentence that we learned in the neurology residency is time is brain. And that is very important. I mean, as we know that every minute counts in that situation. If you think about all the disease that time is very important. There is no more time sensitive condition if you think about the stroke and compared to the other disease. If you think about every minute, so every minute if you save, if you can get TPA faster every minute, you can save 1.8 days extra health life in a patient that received TPA. If you think about a mechanical thrombectomy, you can save extra health, 4.2 days extra health days in those patients that go to the mechanical thrombectomy for every minute. Every minute also, if you think about the recanalization achieved, the TIC2B and the TIC3, you can save 4.3 days health days in their life in those patients that achieved those recanalization. And also in a very young population, less than 55 years old, and also in that score 10. I mean, we're talking about a young population, very active, working in as a father or mother, so it's very active and very important in the community. So if you don't work very well in those patients, you can decrease the outcome of this patient. So every minute that you treat those patients, you can save up to 1 week of health life of those patients. So in that, when Dr. Shah talked about transfer patient from hospital to the other hospital, the door in and door out time, that is very important in that scenario. So if you think about door in, door out, the likelihood to receive a mechanical thrombectomy patient every extra minute decrease 0.5 to 2.5%. If you think about good outcome, drops approximately 0.25% every minute in delay in the transfer of the patient. So that is very important, the communication between those hospitals and decrease the time, wasting time in transfer those patients. Next slide. So this is the actual or the more modern type of scenario that we use when use the artificial intelligence. So that's the number in green that show how many minutes we can save if you use artificial intelligence. So as Dr. Shah said, so when you have one platform to see a CAT scan, to communicate between physicians, to review the imaging, you can save significantly about 100 minutes when you door in, door out of this patient. Because I mean, if you think about the standard protocol, what's happened is when the patient go to the referral center, the ER physician gonna see the patient. They have to wait for the radiology read. When they have the potential LVO, they have to connect or call the interventional center. They have to call and they have to communicate. So those steps is just add more time in the delay of this patient that goes to the other hospital. So if you do with artificial intelligence, you avoid all those other steps, and then we can gain 100 minutes to transfer the patient out of the referral hospital. If you think about minutes or transportation, is about 1 hour less the transfer of the patient. In a door in, to recanalization or to the puncture time, you can save 86 minutes. In the slide, the previous slide, I talk about extra minutes can drop the outcome of this patient. So if you decrease the 100 minutes plus 52 plus 86, it's more than 3 hours delayed that you can save with the artificial intelligence and communication between the physicians. Next slide. So this is very historical for Viz and for us also. This is the very first case of the VIS in the world. So that happened here in Chattanooga. And it also involved Dr. Shah was involved in this case, and Dr. Devlin. That was an 87 years old that came with a completely right side weakness, aphasia, complete typical left MCA syndrome. And when I scored 22 with M1 occlusion, as you can see in this red arrow. So, and then you can go forward. Next slide. So that I'm going to talk about, start from the left side, the first slide, going from the bottom to the top. So if you can see, the CT scanner was done at 5:26 p.m. 6 minutes later, the CTA was done and then was released in the VIS. 13 minutes later, Dr. Shah reviewed the CTA and already saw that there is occlusion in the distal left M1. So he already communicates the physician in the other facility that there is a left M1 occlusion. And the VIS was sent alert a few minutes after the CTA was released. So they talked directly to the ER physician to transfer the patient. And simultaneously, also Dr. Shah was talking to the IR team for this potential mechanical thrombectomy. So next slide. If you think about door in, door out, one more time. Sorry, we'll come back. So if you think about next slide, sorry. If you think about door in, door out, was 49 minutes. So the time that patient arrived and the time the patient left was 49 minutes, less than 1 hour. So the patient had about 30 minutes to arrive in the hospital. And so the RI team just got a CAT scan, just make sure everything is fine, and then was transferred directly to the IR suite, and the patient had a mechanical thrombectomy on that day. So the in-night score was 22, and then next slide. We had a permission of the patient. That's the patient that was the first VIS case. She's 87 years old, a very nice lady. So she was completely almost back to normal a few days after the thrombectomy. So this is an importance, and that's what we want, the smile face when you do the thrombectomy when you treat those patients. Next slide. So with the VIS, what you can do is there is a lot of features that improve the communication between physician and between hospital. One of them is a group message. You can communicate between a group of physician. Also, if I want to communicate direct to the Dr. Tenwe about one patient, I can connect direct to him or Dr. Shah. So, or if I want to talk about a specific patient, I can just hit the patient that I want to talk about, and also I can communicate. And it's a HIPAA also protocol in that type of communication. Next slide. The other feature also is for CT perfusion. You can threshold and customize the CT perfusion in different TMACs. Also, type of alert that you want. If you want to just VIS alert as a push, or SMS message. Also, you can customize that type of imaging. The other features are very important is, next slide, is the mini EHR. You can put the in-night score, baseline MRS score, just like a baseline of the patient. So when someone is seen in the other hospital, you don't need to call the patient or the other physician, the other provider to talk all about the patient, because everything or all the basic information is already at the VIS. So in the other that I really like that is the 3D rotation. I mean, as we know, sometimes it's very clear evidence of large vessel occlusion in the M1 or distal ICA, but sometimes it could be tricky if you see in a very Churchill's vessel or very in any 2 and 3, you can just rotate, and you don't lose quality of imaging when you do rotation. You can zoom in, you can zoom out. So that's very important. You can also send that imaging to the to the physician that you want talking about. So it's a very good to discuss. It's very good to see if there is any any question about large vessel occlusion. And also you can do MIPS, you can decrease the MIPS. So this is a very important features with a losing quality of the imaging. Next one. And also one of the most recent feature that was just released recently was the neurointerventional button activation. So if you think about when you are neurointerventional, you have to call the entire team. So you have to, or the intake have to push the a button or go to the message to the team. So we have to call the interventional tech, nurses, anesthesiologists. So it's 5-6 people that is involved in that. So if you have just a push button and then automatically all the information go to the people is taking care of this patient, you can waste, or you can avoid wasting time in that scenario. So this is one very typical, one very important thing that just released from this. And we just used a couple of days ago that here in our facility at CHM Memorial, that patient came with a stroke. Dr. Shah was already talking to me about this potential LVO based on the exam of the patient. So when I saw the CTA, I already pushed the button, and then actually a few minutes later, the CT, the radiologist read as a large vessel occlusion. So we gained like a 5-6 minutes just push this button and I'm not waiting for that. In the meantime, I already contact my team. They already setting up the table even prior to activate the IR. So this the communication is very crucial for outcome for this patient. Next slide. So that's the case that I was talking about, that also distal left M1 patient was aphasic, was right side weakness, and that pretty quick the patient was transferred to the IR suite. And actually after the thrombectomy, the patient started to move the right side. So that's we want in most of the cases, in all the cases actually. Next. So in the other features that also we are doing here in that facility, the strategy is a transfer from the hospital directly to the our IR suite. So there's a lot of papers in talking about that. I mean, we know that is feasible, is also safe to do that. In the next, if you think about door in, door time, if you go directly to the IR suite or go to the ER and then go to the IR suite. So if you can see here, the difference between the first one is door directed to the angio suite, and then the second column is door to ED. This, if you see the difference between the puncture, door to puncture to door to from one is to the other, is a 15 minutes if you go direct to the IR suite. It's a 71 minutes if you go to the ER, go to the CAT scan, come back to the ER, and go to the IR suite. So it's more than 60 minutes, almost 6 minutes, that you 1 hour that you can gain if you go direct to the IR suite. And plus, I mean, puncture to recanalization is faster. Door to recanalization is much faster when you go direct to the angio suite. And also TIC2B, TIC3 is 91% and 81%. Maybe because of the clot is a little bit easier to remove, or because it's more close. So there's other features that could explain that. Next slide. And also, if you think about independency, in the 3 months, in the 90 days, if MRS 0 and 1 is much higher when you compare when a patient goes directly to the angio suite, when you go to the ER and then go to the angio suite. And also MRS from 0 to 2 is much difference higher when you go to patient go directly to the IR suite. And that's that we talked about even before, that the extra time if you gain, the patient can have better outcome. Next slide. So, and also if you have ability, if you have a IR suite that they have ability to do a CT, a CTA, CT perfusion as we have here. So also we can also, if patient comes to the ER, you can skip the CT scanner in the ER and go back to the IR suite if you suspect for LVO, and then you can do CT, CTA, CT perfusion. If you have LVO, everything is feasible, and then the patient's already there, and then you can do thrombectomy. They show there also the minutes for standard protocol in a transfer direct to the IR suite. The time for puncture is much faster, 29 minutes compared to 1 hour and 11 minutes. From the hospital, from the door to recanalization is 1 hour and 15 minutes. We want to go direct to the IR suite in 1 hour and 53 minutes. So all those numbers, and also it's not risky. I mean, if you think about symptomatic ICH, actually it was higher in the standard protocol compared to the patient that went direct to the angio suite. So it's a thing that is a strategy that it's getting more popular right now. Of course, every hospital, they have different reality, but if you have ability to do that, I think that the patient will benefit with this type of strategy. Next slide. So this is our direct to the angio suite. So first of all, when you have imaging that we can share with a VIS, is much faster also, but also if the other hospital, they don't have access to the VIS, they can push the imaging over to us and then we can review. And also we can decide if the patient needs to come or not. So and also we check the flight to see what's the ETA. The vascular team is always waiting for the patient, or either in the helipad or in the ER, and then transfer direct to the IR suite. When you do this type of a strategy, usually this time is, next one, is less than 3 minutes when you do that. So, or either from ER to the IR suite, or from the helipad to the IR suite. So we know that this is feasible. It's safe to do that option when you're talking about a large comprehensive stroke center. And if you do that, I mean, the outcome of this patient is much better when you do like go into the ER and then go to the angio suite. Thank you.
Thank you so much, Dr. Lima.
All right, I will share my talk. Let me know if you can't see it, but thanks for that. That's all the tips that Dr. Shah and Dr. Lima shared are kind of, I echo all of them. My journey for kind of helping us build an award-winning stroke center here at Baylor in Houston at the medical center was very similar, a change of culture, incorporating technology, using certain what other people would perceive as weaknesses as strengths and vice versa, or using strengths as well. But all those things are well said, and I'm going to focus on other parts of the whole process in addition to VIS being kind of very important and critical for all of us. A little bit about actually the center, because there was a question in the Q&A about how many spokes do you have so to give you a sense of at least our hospital, we are a 18 hospital system with 2 of them acting as comprehensive stroke centers. The 2 comprehensive stroke centers are about an hour apart. And amongst those, the other 14 hospitals or so are the spokes to those 2 hubs. And by kind of geographically doing that, that serves, I think, the patients in the best interest. The territories are easier to divide up. And the other part of that question was getting VIS at those, spokes. And that's, I think, the big critical game changer for us. As speaking from a practical purpose, there's issues of what we call system leakage, where cases that are supposed to stay in the system get lost, and so VIS helped with that when we started. The door in door out time that's been discussed, that helps. And so the big model over here for a multi-spoke hub stroke center really does incorporate good communication, good detection, and good, a transfer of care to the mothership. Here are my disclosures and conflicts of interest. So in addition to being a gold sort of level, there are higher standards of quality that the American Heart Association has kind of outlined. And these are just kind of different levels of excellence. This year for the first last year for the first time, we achieved the honor roll advanced therapy, which was the first hospital in Houston to get that. And that means your door to thrombectomy or door to device time. So as people who are familiar with these metrics, usually it's been door to groin, 90 minutes. Well, now for, as things get better, the levels of excellence and the metrics of excellence are getting tighter and tighter. So door to device, meaning not only the groin, but from the groin through the arch into the brain with the device deployed, is now door to 90 minutes for directly arriving patients to your ER. And if you're transferring patients, because they understand that transfers will be quicker because they've already had the CAT scans and the CTPs and the and Viz detected all that stuff outside, that standard is lower than 60 minutes. So to achieve the advanced therapy honor roll, more than half of your patients, the majority of the patients, have to be below those metrics. And it takes a lot. Viz is an important part, but there's definitely other things. So in addition to these metrics, which is a great way to let the community that you're in know that you've got their best interests in mind, is it's important for the new US News rankings as well. For those of you who are involved in talking to administration, this is speaking a similar language to them. Having your US News ranking for your local region, as well as if you're on the national platform, as high as possible is critically important for marketing campaigns, for other things. And for the US News ranking, there actually were only 2 scorecards in addition to this general kind of body to do that. But within the Department of Neurology and Neurosurgery, both those things linked together, stroke was a scorecard, as well as spine. So making sure you're excellent in all these metrics. I mean, this is just a screenshot more of this page: survival, discharge to home, reperfusion therapy. All these have to be excellent, very high for you to maintain that. So when you're speaking to your administration, US News always kind of makes their ears stand, and so you can kind of bring that actually helps that ranking as well. So our own improvements, this line, the blue line is our door to groin time in 2020. Prior to me joining, also 2020 is a weird year because of COVID. A lot of systems failed during COVID in terms of these quality metrics, and so you can't always compare to 2020, but in terms of the 3-year outlook, these are the door to groin times. 2020 was blue, black was 2021, and yellow is where we are in 2022. The green line is a 90-minute mark. So staying consistently below that is extremely important for these metrics. In fact, I think this is a little sort of stretched out in a wrong way. This little dot, this high dot, shows it's above 90 minutes, but actually it's 87. So, the highest being 87 for that whole year on average per month is fantastic. You just want to keep that below 90. And, certain months as low as 41 minutes, 52 minutes, 47 minutes for door to groin. Other things that impacted us greatly was the spoke model that I was talking about, door in, door out times. These are minutes saved. So compared to before Viz and after Viz, we've got 50 plus minutes saved. We've got a few spokes that are out of network. They're not affiliated to our hospital, but they like the services we provide. We're always available, and they need a place to send their thrombectomy. So they've understood that, we'll send our patients to you. Viz has been very helpful in solidifying that agreement, because if they have Viz and we have Viz, we can link them, even though if they're out of network. So that's been a very fruitful endeavor, and they've been very happy with that. So, how do you improve these metrics? There's a great quote from a good friend and a former chief medical officer. To improve something, just start measuring it, and that's true in my personal life with measuring my weight or whatever it is. But as soon as you just make the intention of starting to measure something and tracking it, you'll see the improvements just because you're more cognizant of it. This is also known as a certain bias when people are starting trials and they come up with all these metrics. As soon as you start to trial, the measurements the improvements happen almost immediately. So very important for there to be a very methodical way that these things are being tracked for the purposes of reviewing, maybe at a weekly, bi-weekly conference. And that often goes a long way. The biggest change is culture. Forming a culture focused around good and safe outcomes is important. Here we have our great team over here awarding a Brain Saver Award to a tech that was involved in a very quick, efficient, good outcome thrombectomy. So just making sure your team is motivated as much as you are to provide the greatest, fastest care that you can. So starting from the bottom up to wherever it is, and thinking about this whole process chronologically, I think Dr. Shah, Dr. Lima, and myself may be the least important part of the people in the whole process. And it's just everyone else who's kind of part of it, and making sure they understand that and it's recognized is extremely important. So something like the Brain Saver Award can go a long way. So a problem for a big place like Houston, which is very urban, is and there's a lot of text here, but what it is the process we have of activating our team. And so I'm focusing more on the backer end of the later end of all this stroke and the thrombectomy is how do we get techs, nurses, myself, my fellows, residents, whoever in the hospital ready at the same time if the patient's in CAT scan, which is just 2 minutes down the hall from the IR suite. And as soon as the CAT scan's done, they're going to be there in 2 minutes. So in a place like Houston, where people can live as far as 45 minutes away from the hospital or even an hour, an earlier activation is critical. And so for a time being, we move to a clinical activation, meaning that if someone in the ER suspects an LVO and NIH is greater than 6, and there's plans of even getting a CTA or a CT and a CTA, then NeuroIR is activated. We were very excited to potentially use VIS as the form of activating, but our hospital is committed to a HIPAA compliant communication system called Tiger Text. So for us, it's Tiger Text gets sent out as a critical alert that there is a patient. For people like me who may live closer, or the residents who are in-house, that's just, okay, we should get ready. But for people who live farther away, like the techs and nurses or anyone else, my partner, they use that as, okay, let me finish up what I'm doing and start to get going. Worst case scenario, I may just have to turn back if it's a no-go, but if it's a go, at least I'm halfway there or almost there. And so that whole activation process based on clinical suspicion has definitely been one of our biggest areas of improvements to our metrics. But the big downside is the false positives, the ones where you think there's a stroke, there's an LVO, but the scans show everything's fine. Turns out it was just a seizure or perhaps a bleed or a brain tumor or something else that was mimicking a stroke. So there is a false positive case as high as 30 to 50% has been shown. The better and, the more you do it, the more accurate it can be based on the team that's assessing it and all that stuff. So you hope for a 30% or less no-go rate, because you don't want to falsely activate this team too often. I'll get to a little later point that, how do you pitch this to the administration and the team members as well. Stroke alerts and activation from outside OHS, meaning outside hospital transfers, those are often the smoothest because coming in that they have an LVO, you see it on VIS, I'm able to look at the arch, know the setup, the table's ready, my catheters are open, anesthesia's there waiting, patient shows up and we're ready to go. It was mentioned by Dr. Lima about knowing the flight travel time. There's a great free app called Flight Radar 24. Here's a video of it. It's like looking at your Uber approaching. Here's the helicopter right in the middle of the screen. It's right on the outer borough of Houston, or outer edge of Houston, and here's the Texas Medical Center. So this is on the phone. You can see the helicopter approaching the medical center. The moment it gets here, and if it disappears, that means it's landed. But the closer it is, I'll play that once more, the closer it gets, and you can see it moving in real time. It really is like an Uber. You can kind of really use that, and the whole team has that just in case, they're like, I'm 10 minutes away, I'll hang out here, and when I see it getting closer, I'll make sure I'm ready. And so that can help ease the burden of showing up and then being frustrated that the patient's not there yet, or there's further delays because of air travel, because of storms, weather, whatever it is. Anesthesia considerations. So the other part of this factor is, where does anesthesia fit in? And every hospital has probably got a different relationship with anesthesia in terms of, do they show up for the cases? Is it nursing sedation? Is it anesthesia? Do you do yours awake versus general intubation? Our preference is intubation because we often get very complex cases, and if they're moving around, we may have a difficult time seeing it. A lot of it is operator dependent. There's data to say both are good outcomes. We've done other things to save some time. No A-line unless there's active cardiac issues. Invasive arterial monitoring has not been shown to be super beneficial. And if it ends up costing another 5 minutes because anesthesia is working on an A-line, it may not be worth it. Also, if they do need an A-line, often you can get groin access and A-line access at the same time, and other ways around that. No Foley saves another minute to 2 minutes, or you get into a situation where the patient just got TPA. Technically, Foley placement after TPA is not indicated. So if the thrombectomy is going to be quick, and even if it's prolonged, you can always put the Foley in afterwards. And all these other parameters, discuss, protocolize as much as you can. Emergency cases workflow should be, predetermined as well. Often we don't have labs, but you should still proceed, and they could be reviewed as they come back. Verbal consent or emergency consent protocol. Families are often not with these patients. The patients can't consent. You should have a smart phrase in your epic that kind of clarifies that. Other points, intubation and groin access can happen at the same time. Everyone has a certain job. I'm helping, getting groin access or whatever. The tech is getting the table ready. The nurse is helping anesthesia, and it's just a very kind of good orchestrated effort with everyone clear, defined roles. It's not just, hey, everyone just help wherever they can. They all know what they're going to do. And nursing documentation, as everyone can attest, is sometimes slows down patient care. So patient care is important. The documentation could sometimes happen simultaneously or just shortly after the critical parts, but not extremely important to have everything documented and then helping the patient. So all those things were accounted for, and people understand that. We're now moving to a 24/7 in-house model. Not feasible for most centers, wasn't feasible for us because the volumes were not there, but the last 2-3 years our volumes has increased. So we are moving to the techs and nurses will be in-house 24/7. If not, home call and early activation. With the early activation that I talked about, calling them in and having them go back if it's a no-go. We did discuss that if it's a no-go, they still get 2 hours of overtime pay, which is more than the time that they were used. So there is a financial incentive that even if you get called down, that it wasn't a waste of your time. And that has to, again, be pre-understood and determined by your administrations. And it is worth that 2 extra overtime of pay to make sure you're getting these metrics, because it helps the US News, helps it, et cetera. And ultimately it's good for the patient. And so that kind of wraps up maybe a 360 look at what are some other factors that helped. I know this leaves only 12 minutes for another part of this talk, so that's why I wanted to kind of cut it short, and I'll pass it back. But my email address is here if anyone wants to reach out, and hopefully we'll have some time in the end to answer some of the Q&A questions I've seen. I'll go ahead and stop my share.
Thank you so much. And thank you and kudos to all of you and your teams for the work you're doing in the stroke community. Prior to being at Viz, I had the pleasure of building 2 stroke programs and neuroscience programs. I know how hard it is, and want to also thank American Heart, American Stroke for continuing to hold us accountable and push us for better patient care. I remember when the metric came out on the door in, door out, and I was like, there's no way anybody's ever going to be able to achieve it. And we have been able to. So as we've heard throughout the presentation, we heard a lot about the importance of the stroke program being in the ground center for a lot of neuroscience programs, how that relates to US News and World Reports, as well as Dr. Shaw. I think you did a really good job on highlighting around the economic growth of programs and how important it is for stabilization in hospitals to continue to offer services to patients. So I want to talk just a little bit around aneurysm and subdural. I'd love to get your guys' feedback on how you consider program growth. But we recently have had 2 new approvals and brought 2 new products to market, which includes aneurysm and subdural, and we think about how this helps contribute to growth within our neuroscience programs beyond stroke. We know that we have to measure aneurysms and ICH for our comprehensive stroke programs, and subdural is really leading some innovative changes coming in. So talking a little bit around that, it's a little bit different of workflows than stroke, especially for the aneurysm. This is more about capturing the most appropriate patients that often tend to leak out or don't necessarily always get to the appropriate specialist for follow-up. So we really wanted to focus more on that management of finding patients, capturing them within the health system, and helping to track them so we can ensure they see the most appropriate physician and specialist. Subdural, a lot of advances happening there within so a lot of clinical trials going around internationally, big ones around MMA and how we continue to treat these patients and hopefully demonstrate better outcomes. So this product is really exciting to see, as we know subdural is going to be the largest neurosurgical diagnosis by 2030. So we had the opportunity at SPIN I think it was last week, I don't know, but 2 weeks ago, many of us were there, where we were able to have Dr. Sheath release some data coming out of Texas as well. And he really looked at a retrospective analysis of his scans, and there was about 1,100 stroke CTAs that he analyzed. And we found that 85% of patients that we found with aneurysm on the AI had not been previously referred for follow-up. And, we were all kind of shocked at actually thinking these would be small. They would be 2 millimeters, 3 millimeters, it would be cavernous or infundibula, but actually they were pretty big in size. You can see 45% of them were greater than 7 millimeters and 55% were less than 7 millimeters. So really identifying that, I think there's a workflow opportunity here of capturing patients, keeping them within the system, and ensuring they get to you all for appropriate follow-up care, and hopefully preventing them from ever rupturing. We know, aneurysms are being, some of the problem is that there are a lot of incidental findings. Maybe they're not picked up. There's inconsistent care pathways of how do we have an incidental finding and we make sure it gets to the appropriate specialist. Patients leave the hospital and sometimes healthcare is complex and they're not sure how to navigate. And really just kind of inefficient communication and breakdowns. So really, those were the problems that Viz was trying to solve as we were thinking and working with clinicians to build the aneurysm product. So again, you can see this here. It's doesn't need to be alerted, non-acute, but you're able to get those notifications into a patient list where you or your APP can review them. There is also the ability for the radiologist to have this flagged on their work list and their integration with PACS. So that really helps bring the whole care team together. So we're making sure we're capturing these patients and not losing them. And you're able to send them directly to your clinic. So I think this is where a breakdown happens. A lot of times patients will leave the ED with an incidental finding of an aneurysm and say follow up with a physician in 6 weeks, and they go home and they probably never look at those paperwork. So this allows us to bridge that gap for patients and make it easier for them to make sure that we are sending it to the clinic and the clinic is able to pull those patients in without the waiting for the patient to go home and call and then never come back and then comes back with a ruptured aneurysm and a subarachnoid. Subdural, I'll touch briefly on this. Really excited about what's going on in this space over time. Previously, the treatment for this was medical management as well, or cranny with burr holes. And we know patients would spend long length of stay in the ICU, but MMA has kind of brought some new innovative treatments for this. So, we just did a publication on this one as well, making sure that we're bringing valuable AI out. Sensitivity and specificity, as well as PPV, were significantly high. So 91% sensitivity, 96% specificity, and our PPV was 95%. And really what we're focused on for this product and what our driver was, one, making sure patients get routed to this new innovative therapy if they can be, as our product's being used in a number of the clinical trials, but also really focused on how do we look at this from a cost and an economic perspective. We know that the cumulative cost for chronic subdurals is pretty high and there's a huge impact. And we also know that this is going to continue to rise as we see the aging population rise and people are living longer. So we're expecting by 2030 to have an annual payer impact of 4.8 billion. So this is really looking at how do we help route patients to that appropriate treatment to help maybe kind of reduce some of these costs as well as disability associated with the disease. So I'm going to stop there. I'm going to open it up to Q&A. I know we had a couple come in, and I know we answered some of them live, but want to go ahead and see if we have any other ones. Question came in, and this, we can open this up to anybody. If you have an LVO alert coming from a primary stroke center out of network, how do you handle the notification from the primary stroke center? And how do you know it's a false positive or not? Does your center read, or does the PCS send their RAD reads? So I think you both can, anybody can answer this because you guys are receiving from out of network referrals as well.
Yeah, I can take it. I think means usually when we are getting this kind of LV alert on our phone with the outside hospital, usually the benefit of this is like it's going to come to the one of the vascular neurologists or intervention neurologist at the hub hospital, and usually they're very used to look at their own scan, especially when it comes to LVO. It's very proficient to look at the LVO, whether M1, M2, or ICO occlusion, and they make the determination that this is a real LVO, and then most likely if it's already like you have a mutual agreement with that hospital, that we usually kind of your designated hub center, then our provider will pick up the phone and call the transfer center. Hey, it seems like a LVO, but it could not be related to patient symptoms. So we still have to talk to the hospital to find out what's going on with the patient and get that information. But usually one of the provider, the neurologist or intervention neurologist or neurosurgeon, look at that and make the determination to call the spoke center.
Great. Another question that came in, I guess I can answer this one. It's more around the platform. So a question came in with the new platforms. Has there been any discussion of integrating Viz timestamps or documentation into Epic or any other EMR? So we actually do integrate with Epic and all EHRs. We're agnostic. So we do have that capability. So if you are a Viz user, we're happy to work with you and your clinical informatics team at your hospital to help get that information over to your EHR. Any other questions? I think we got most of them that came in. Okay. So I think we'll go ahead and wrap. I want to thank everybody for attending, and thank you to our panelists for sharing your experience, and kudos to all the amazing work that you have been doing. So continue to drive stroke programs forward, and thank you.